Thanks a lot. It has been a real pleasure to get an invite from a dear friend, Dr. Neeraj. We know each other for almost, 2 decades now. And the topic of exocrine pancreatic insufficiency, in fact, is one of the most important topics in gastroenterology, where we normally, do not talk about much nowadays because everybody is busy talking only about pancreatitis, either acute or chronic. And we keep on forgetting from the endocrine part of it, the exocrine part of it, okay? As a matter of fact, we have got a wonderful speaker, Dr. Rajesh Gupta, who is a director of clinical sciences at the most prestigious institute of India, the AIG Hospitals, Hyderabad. I invite Dr. Gupta to give us deliberations. Before that, the only thing, we basically will talk about is he's going to give us, or rather, he will take us to the journey through what are the symptoms, signs, and what are the overlap symptoms of pancreatic exocrine deficiency with IBS and other things, and what tests we need to do it. I would like to congratulate you all, for a wonderful thing. I thought it was more of a pathological meeting, but whatever I could hear in last almost an hour, which I've been hooked into, I found that, this is more of a clinical talk than the real diagnostic talk. So it is not pathology, it is basically what we call as pathomedicine. So wonderful. Thanks a lot. Dr. Gupta, please.
Thank you, Dr. Aggarwal. It's a pleasure and indeed honor for me to be part of this interesting meeting. And as you said, Dr. Neeraj is also a very good friend of mine. And on behalf of AIG, our team and myself, I would like to congratulate Dr. Neeraj and his entire team for hosting this wonderful meeting. As Dr. Aggarwal has rightly said, it is a more of a clinical application of laboratory sciences, how to collaborate with the laboratory science. It is equally important because we talk a lot about the laboratory to make it interesting. It is always the clinical application which matters a lot to everybody. So what is the clinical application and how to interpret the test? That is the crux. And my brief is to talk about exocrine insufficiency and laboratory diagnosis as a clinician, how we interpret when we order these tests. That is what I'm going to talk in next 20 minutes or so. So, do you have my presentation, please? Can you see my presentation, Dr. Aggarwal?
Yeah, it's
yes,
visible,
sir.
sir.
Okay. So, pancreas is a unique gland in the sense that it has both exocrine and endocrine functions. And as you all very well aware, diabetes is the most critical endocrine part, which is because of pancreas. But that I'm not going to cover because it is going to be covered by somebody else, and it is a different issue at all. So as a gastroenterologist, we always concerned about exocrine insufficiency. What is exocrine insufficiency? Because it's basically reduction in pancreatic enzyme activity in the intestinal lumen, which leads to a threshold, below a threshold, which is not able to maintain normal digestion, and in process, which in turn leads to maldigestion. So this is what exactly, and because it leads to maldigestion, it has its own clinical consequences. That's why we are concerned. So how it happens? It happens because of the progressive loss of pancreatic cells, and over a period of time, it results in maldigestion and clinical consequences of. As a matter of fact, the exocrine pancreatic insufficiency results as a result of chronic pancreatitis, but it can happen in acute pancreatitis as well. But it's chronic pancreatitis is the major cause of exocrine insufficiency. As the disease duration increases, as we said, and as a clinician, if somebody is having chronic pancreatitis, mild pancreatitis, which over a period of time, as the duration increases, the prevalence of exocrine insufficiency will also go hand in hand, and it will increase. And roughly after 12 years of chronic pancreatitis, roughly 50% will have significant pancreatic enzyme insufficiency. So that is a very significant problem. As I said, as a clinician, we should know what are the causes. So there are different etiological factors which can lead to PEI. And the most important thing, loss of pancreatic parenchyma. It could be because of recurrent attack of pancreatitis, which in turn leads to pancreatic fluid collections, which can lead to wound, which in turn leads to loss of pancreatic parenchyma. If there is a prolonged obstruction of pancreatic duct, it can also cause pancreatic enzyme insufficiency. If there are certain factors which lead to stimulation of the pancreatic enzyme, if they are deficient or if they are not there, so it can also lead to insufficiency. Sometimes the pancreatic enzyme, because of acid exposures, they get destroyed, because I will come to later on this aspect, so they can. And of course, lastly, if the patient has undergone major resections involving the pancreas, can also lead to pancreatic enzyme insufficiency. So we have to, when we analyze this patient, we have to factor in the historical aspects and take into account all these causes which can lead to PEI. So what they present, this is a brief presentation, because it's a clinically how they manifest. Sometimes they may be asymptomatic, as if there is an frantic, if PI is mild, so clinically it may not be visible, or it may not be overt symptom. But if somebody who is having steatorrhea, that is, it means the patient has already significant PEI. Some patients, and as a result of that, because of maldigestion, these patients tend to develop weight loss, they tend to develop diarrhea, and sometimes because of the underlying pathological conditions, they can have abdominal pain, and obviously they might have some loss of appetite, nutrient malabsorption, which can be clinically deciphered. As I said, pancreas is an organ which leads to release of three important enzymes, that is amylase, protease, and lipases. Amylase and protease deficiency can also occur, but this is very well compensated, because the other organs in the body also lead to secretions of amylase and proteases, and which can be very well compensated. But it is the lipase deficiency which is very critical, and it is primarily the deficiency of lipase which leads to clinical consequences. And as a result of that, we are always focused, when we analyze and when we do pancreatic endocrine insufficiency, we are primarily concerned with the assessment of lipase deficiency. And that's the crux of whole laboratory diagnosis of pancreatic exocrine insufficiency. So because, as I said, the lipase is responsible for fat digestion. So if there is significant pancreatic enzyme insufficiency, it will lead to fat maldigestion. And when it occurs, when the lipase deficiency goes below, lipase production goes below 10%. So if there is significant decrease in the production of lipase, it will lead to PEI. And as a result, because the lipase is not compensated, as I said, amylase, lipase, they're secreted by stomach and other organs also, and so it is compensated. Whereas lipase is not compensated by secretion from other areas. So it is primarily the pancreas which is responsible for production of pancreatic lipase. So that leads to significant PEI. So this was an elegant study which was published long back in NEJM, in very old study, which has clearly shown that if the lipase production goes below 10%, then it leads to fecal fat maldigestion, and with the fecal fat will go up more than 7 grams. This is where this chart clearly shows that if there is a lipase production is less than 10%, the fecal fat output will grow more than 10% and subsequently much more. And that is how we define basically pancreatic exocrine insufficiency. This is a very simple test, and I'll come to these tests later on also. So what is severe? Severe means if there is overt. And when it becomes overt, if the lipase output is less than 10%, one, fecal fat excretion is more than 7 grams per 24 hours. Basically, this is more than 7 grams is for non-diarrheal patient, and coefficient of fat absorption is less than 93%. So it is all boils down to the basically lipid digestion, fat digestion basically. So So earlier we used to treat these patients based on the severity of exocrine insufficiency. If the patient has significant PEI, that is pancreatic enzyme insufficiency, and if there is over diarrhea by clinical history, that is significant steatohepatitis and fecal fat was more than 15 gram per deciliter, we used to treat this PEI. But now the concept has slightly changed, because what we have said that clinically it may not be visible, means because there is no overt steatoria, but there could be still occult. And occult PEI has its own consequences. And when it occult means the fact is roughly between 7 to 15. Patients are clinically asymptomatic, but the studies have shown they have increased cardiovascular events. Cardiovascular disease go hand in hand as the enzyme deficiency develops. And it also leads to osteoporosis. This was study which published long back. And this clearly shows that if you follow these patients of chronic pancreatitis, the significant increase in mortality of because of cardiovascular disease. So it was an interesting why the patients who has chronic pancreatitis should have cardiovascular mortality increase, because of increased risk of atherosclerosis. And the patients they have shown that these patients have occult steatoria, and which in turn leads to decreased HDL, decreased lipoproteins, and vitamin nutrient deficiencies are there. And the beauty of this study was that these things could be easily corrected by pancreatic enzyme replacement therapy. So there is a therapy also, and that's the concept of treating occult pancreatic exocrine insufficiency came in, and that's the reason we should assess the pancreatic exocrine insufficiency. Because if the symptoms are overt, obviously the patient will report to the clinician, we will examine and we'll do studies. But if it is not there, then these patients can be missed, and which in turn has clinical consequences later. So what is the treatment goal here is to not only normalize fat myelinization, it is obviously to treat both overt as well as occult pancreatic enzyme insufficiency. And the treatment is very simple. You have to give pancreatic enzyme replacement therapy. So there are different ways. How, as a clinician, how do we diagnose? So there are certain methods. There are clinical. First and foremost thing is obviously the clinician. As a clinician, you have to take a detailed history, elicit the signs and symptoms of the disease or the deficiencies which is already set in. Is there any clinical setting where there is a possibility of developing pancreatic enzyme insufficiency? As I said, if there is a pancreatic surgery or the patient has past history of pancreatitis, when any dissections have been done or when any necrosectomies have been done. So all these things, details we need to highlight and the history, and you should go into that. The second important thing is these pancreatic morphology we can study by imaging studies. We have cross-sectional imaging, ultrasound, CT, EUS these days, and of course we do MRCP. Then comes to the assessment of lipase, that is maldigestion, that is by simple test is spoon test, which all of you we have been doing from our medical school, and the fat. And then comes the indirect test and the direct test. Obviously these are tests which assess the deficiency of pancreas and which gives us very clear idea that whether the patient has pancreatic exocrine insufficiency, whether it is occult or whether it is overt or whether it's severe or mild. So let us look at these tests one by one. First, coming to the direct test, there are two ways to do it. One is direct test and the other is indirect test. Indirect test means the test which give us idea of whether the maldigestion is set in and what are the products which are elevated or decreased, so that we can say whether yes, it is an indirect evidence of maldigestion. Indirect test I will come separately. The direct test first I will cover, and they are mainly the stimulation test, what is called the secretin test, cholecystokinin or mixed test, and then Loom test. The problem, these tests, the problem with these tests is, direct test is, they are very cumbersome. As I said, okay, you have to put in the tube, you can directly put in the tube, you can do endoscopy endoscopically also. So these tests, just a brief idea about these tests. These tests are basically to stimulate the production of lipase, and which will increase the, we assess the assessment not the lipase, the product, that is bicarbonate, pH, and the volume, how much secretions we obtain. And these are the tests, and that is how this is. There are two ways, as I said. So first is collection of the duodenal aspirate and the gastric aspiration by putting a special tube that is called drailing tube. It is tube put through the nose, and then we estimate the basal, gastric, and duodenal pH by aspirating the gastric juice and the duodenal juice. Then we give a secretin in bolus dose, and then we start collecting every 15 minutes the allocates every 15 minutes, and then the aspirate is assessed for the volume, the pH, and the bicarbonate concentration in that aspirate. So this is the concept of this test. So basically, if when we start production in the normal individual, the peak production bicarbonate should be more than 80. Yeah, right? And the volume should be 1.5 to 1.5 ml per kg, and the rate should be 10 to 30, and this is how it goes. So anything which is less, it means there is a not adequate reserve is there, and the cells are not able to secrete sufficient amount of bicarb, and that's the reason pH will go up. Yeah, pH will go down, it will become more acid because bicarbonate is not being produced, and the bicarbonate production also goes down. So anything, if you in this assessment, if bicarbonate production is less than 80 milliequivalents per liter, it means it denotes that is pancreatic enzyme insufficiency. That is basically important, especially if there is no overt deficiency, if the patient doesn't have clinical symptom, but there is a clinical symptom suspicion is there. In that test, this test is very, very important. But this test is very cumbersome, putting drailing tube and all. So now we have alternative method, that is what we call that endoscopic method. In this endoscopic method, we can do the same thing. We can do aspiration by instead of this drailing tube, we put endoscope. But the problem here is, again, we have to put a scope for a long period of time. Obviously, you have to collect the fluid for 15 minutes, every 15 minutes for assessment. So obviously you have to keep the scope over there. And you can imagine if you put the scope for 1 hour, it's a very, very cumbersome procedure. And obviously it will require sedation also. And it's not a beneficial, not very good for the patient and for the physician also, because he has to spend 1 hour putting the scope in. So we always try to do indirect test in that sense. So briefly, the secretin test, as I said, it stimulates the production of bicarbonates, but it is sometimes as an academic institute, we do these tests, and especially those who we want to, as a research protocol in certain situations, we do these tests. Clinical practice, we don't use this test quite often. The advantage is it is a very sensitive test, especially in early pancreatic enzyme insufficiency. Obviously, in advanced cases, these tests are not required anyway, because they were other simpler way to diagnose this. And this obviously involved a lot of cost, because secretin itself is a very expensive medicine. And of course, the standardization will also be required. Similarly, the cholecystokinin is another stimulation test. And it has its own limitation. It has this limitations are it will lead to gallbladder colic, sometimes stimulation, it causes nausea, vomiting, and obviously some in patients it lead to delayed gastric emptying also. Obviously, the patient has not very well accepted, except in the research protocol, these tests are performed. Lund test is meal-based test. Here, this standard meal is a high-fat meal is given to the patients, and it leads to production of pancreatic, stimulates the pancreatic enzyme production, and that's how it's a basically high-fat diet. 67% is primarily the fat in this specialized meal, and obviously duodenal aspiration has to be done. So these tests are obsolete these days, and nobody performs these tests. Now coming to the indirect test. Indirect tests are very easy to perform, and they basically show the consequences of pancreatic enzyme insufficiency, as I said. They can be easily performed, and they are acceptable both to the physician, both to the patient, and they are not very expensive also. But obviously, their sensitivity, specificity, especially in early insufficiency state, is slightly lower as compared to the direct test. That's the reason they are only positive when we do these tests when the patient has significant pancreatic enzyme insufficiency. So coming to the simpler thing first, that is fecal test. So fecal test is the gold standard. It is there for ages. And all of this have been taught in our biochemistry classes, pathology classes about these fecal tests. And the first thing is that it is an indirect test, and it's a very high sensitivity and high specificity to diagnose maldigestion. But the problem here is you cannot differentiate whether this deficiency or maldigestion is primarily because of the pancreatic disease or because of other causes. Because fat maldigestion can happen in other states also. If somebody is at a malabsorption state because of other reasons, so you can't differentiate. You will, this test will be abnormal. Okay, so here he has to apply this test in addition to your historical background of the patient, clinical signs, and other lab, other imaging modalities. So the fecal fat is you can assess by simple qualitative test, that is by Sudan stain, which you do on the stain. Then you can make it a little more semi-quantitative by the number and the size of the stool fat globules. And the quantitative test obviously is the Van de Kamer test, and where you assess the actual amount of fat which is there in the stool. Okay. So as I said, anything which is more than 7 gram per 24 hours, more than 7 gram of fat in the diarrhea, a stool, that is called steatorrhea. This is standard definition. But in sometime diarrheal state, it could be it may be slightly higher. That is, it can vary to 7 to 14, but the specificity is becomes low down. So if suppose if it is more than, it becomes strongly maldigestion. It strongly suggests fat malabsorption. But the important thing one should keep in mind before ordering this test, the patient sometimes they modify their diet because of the fat maldigestion. So in that situation, what you have to do, you have to fat balancing diet. So you should administer high fat diet to this patient a few days, preferably 4 to 5 days before ordering this test, preferably a week. And once this patient's fat optimization has been done, then you order this test. And during this test also, you should do the administration, of the patient should be advised to continue 70 to 100 grams of fat every day, because that is very, very important. Otherwise, your results may not be appropriate. And obviously, these are aesthetic reasons. These tests are not very commonly performed, but these are very, very important tests. As a clinician, as a researcher, you have to order these tests, and whenever there is a suspicion of exocrine. And this again, this is a standard chart. This is a long, which is the slide which I have shared with you earlier also. This was study which was published in 1973 in NECM, and which has clearly shown when the fat output, the lipase output goes below 10%, the fecal fat will go above 7. And that is, it's a very clear correlation as per this chart. And based on that, you can define that the patient has already, if the pancreatic exocrine insufficiency or not. Sudan stain, as I said, it is a very simple test. It is a stool test. It has good sensitivity in severe diseases, or those who have overt exocrine insufficiency, and very good specificity. And as you can make it as a semi-quantitative if there are more than 100 globules or more than 6 micron size high power field. It means there is a significant, or you can quantify it that there is already the moderate to severe pancreatic exocrine insufficiency. Whereas in mild, it may not be. There are some other fat tests or also what we call near infrared reflectance analysis, but these are expensive tests. But the advantage is it can assess what not only the fecal fat, it can assess other nitrogen, like carbohydrate in a simple cell. So it will help in assessing us whether the patient origin, as I said earlier, it is difficult to differentiate in other stool-based tests whether the deficiency which is documented is because of the pancreatic disease or other disease also. Here you can say that the patient has intestinal malabsorption or also, so that you can pinpoint the diagnosis. Another test is acid steatocrit test. It is also a gravimetric test and this is a very specific, but it is also not available because the machines are involved and the people are not performing it routinely. So the another test which is coming off late is becoming very popular is fecal elastase. And the advantage why this test has become popular because it's a simple test and a stool-based test and you can easily perform in all the laboratories. So fecal elastase is an enzyme product of pancreas then and it remains stable in the GI tract. So that is the advantage. So the concentration and it directly correlates with the concentration pancreatic fluid and basically the values, if it is very low, it goes below 200 microgram, it means abnormal and it denotes there is a deficiency or angiocrine deficiency is there. If it is very low, it means less than 100 micrograms, it means it is denotes severe exocrine pancreatitis. And it is a very high sensitivity and specificity if that already if there is a moderate to severe pancreatic exocrine insufficiency is there. But the problem is in the mild disease, sometimes this test may be erroneous. So how do we interpret? So this is very important and this study has been basically has correlated very well that those who have fecal fat, it has tried to quantify this test, those who have less than 100 microgram fecal elastase, it means it is a very sensitive and specificity is more than 90% to say that there is a significant pancreatic exocrine insufficiency as correlated with the fecal fat estimation. So this was an elegant study which was published 2 years back in CGH and clinical and gastroenterology. So because the common clinical dilemma when somebody comes with diarrhea to us is whether the diarrhea is because of functional causes, which is very common in clinical practice, that is IBS, or whether the patient has underlying chronic pancreatitis. So how to interpret the test in that case? So suppose that clinically there is a very high probability, there is a low probability of exocrine pancreatic insufficiency, but you feel that it could be IBS. So in that test, if you order these pancreatic, the fecal elastase test, so what you find is that in this study, that is how they differentiated. They took the probability, low probability of EPI and high probability of EPI. These are two group of patients, clinically they divided. And then they ordered this fecal elastase. And when they found that those who have low probability of PI, it means those who have high probability of functional diarrhea. So when they did fecal elastase and the fecal elastase was less than 200 gram, 200 microgram. So the false positivity rate was 11%. But if it was more than 200 gram, the false negativity rate was only 1.1. So it means if somebody who has a normal fecal elastase that is more than 200 microgram, it means it will rule out exocrine pancreatitis because it is the false negative value is very low. Whereas if there is a high probability of BPI and the fecal elastase is less than 200 million, the false positivity is 7.2%. Whereas if it is more than 200 grams, the false negative is 9.2. So if you say if the values are normal, it means the values are normal in clinical suspicion of EPI, that is exocrine insufficiency, you can rule it. The possibilities, if the value is low, you cannot rule it out. You have to investigate further. But if it is a normal value, the chances are that likelihood of exocrine insufficiency is very low. So that is how you can differentiate on clinical ground by simple test. This is a stool-based test and it is available in the laboratories easily. Another test that is performed in indirect test is breath test. So it is basically the concept of this test is here the carbon C carbon 13 labeled carbon dioxide mixed food is test meal is given to the patient and it is metabolized in by the pancreatic intestine. It is taken up by the intestine, metabolized in the liver and excreted into the breath. So as a consequence, this labeled carbon dioxide will be exhaled and it will be measured by a breath analyzer. So the amount of labeled carbon dioxide, which indirectly reflects the exocrine insufficiency, can be measured by mass spectrometry. So if there is a deficiency of lipase, if there is evidence of exocrine insufficiency, the level of this exhaled carbon dioxide will not be absorbed, it will not be metabolized, so it will not be exhaled. So labeled carbon dioxide will go down. So how much it will go down? It will go down below 29%. If the exhaled carbon dioxide, the labeled carbon dioxide is less than 29%, it has high sensitivity, that is 93%. Specificity is also very high, and these are all very well validated data. So that is another way to differentiate the patient has exocrine or insufficiency or not. And this this study, which has essentially done the same thing, and they correlated fecal elastase with breath test also in patients showed severe exocrine, and they found that taken this coefficient of fat absorption as standard, gold standard, this tool. So to say that these patients are definite documented exocrine insufficiency, and then they performed these fecal elastase and breath test. And what they found that if the fecal elastase is less than 100, the sensitivity is 88%, specific 79%. So not very high as far as the fecal elastase, but in this particular study. Otherwise, these studies, the other data they shown, this is pretty sensitivity and more than 90% sensitivity and specificity is there. Whereas the carbon dioxide breath test less than 29% is almost equal. So this is what is essentially said. So now coming to the morphological test, which we perform every day in our clinical practice. So if the patient extensive calcification, simple skygram, it will show that the patient has extensive calcification. It is chronic pancreatitis, and whether the patient has overt insufficiency, that you can decipher by clinical history. But if the calcification is not there, then you do all these specialized tests with the imaging studies, that is CT, you had US examination, and sometimes we do ERCP, not for diagnostic purpose these days. If there is evidence of like pain, if the patient has significant pain and we have to take care of the pain, and in that ductal hypertension, then do ERCP. And in that time, you can assess the pancreatic imaging also. US has a very important role to pick up early chronic pancreatitis, and it has standard signs. If you have these signs, you can very well make a diagnosis of early chronic pancreatitis based on, but the problem with US is sometimes we tend to overdiagnose these patients. And as I said, if there is a very likelihood possibly the patient has undergone surgery, if the patient has unresectable cancer, these patients are likely to develop pancreatic exocrine insufficiency. So you should always keep in mind whether the patient has undergone surgery or not. Okay. We should assess nutritional parameter. As a clinician, you should always go for the certain examinations. You should not skip the examination by simply doing the test. If there is significant weight loss, diarrhea, steatorrhea, that you can make out by history itself and by simple examination. And then you can order certain nutritional deficiencies, which you can very well find out: albumin, pre-albumin, retinol binding proteins, vitamins, and certain trace element which may be deficient in these patients. These are some of the data which has been shown that in chronic pancreatitis, you can have the deficiency of magnesium, you can have deficiency of hemoglobin, albumin, pre-albumin. These have been very well documented. And these are fat soluble, even BMD has been found to be lower in chronic pancreatitis. So as a clinician, this is a summary slide where you can find what are the tests you are going to apply based on this sensitivity and the cumbersomeness. So first, coming to the direct tests, they are very sensitive, but their practical value is very limited because of their cumbersome nature. Of course, they are available at some centers where we call research purpose, they are used. Fecal elastase is very sensitive, very good test. It is a practically very useful test, and it is available in majority of the centers these days. Similarly, the breath tests, they are also very sensitive. They are used easily, they are applicable to the patient. Patient is acceptability is also good, but they are not available everywhere. Stool test, qualitative fecal test, very sensitive. useful, but practical value because of aesthetic reasons, they are not commonly performed, but they are very, very useful. Stool test, these are old gold, and a stool is considered to be old gold in our gastroenterology. So it is very useful test and simple test, which can be easily performed in lab. Pancreatic morphology, if the other indications are there, you have to always think about pancreatic morphology based on clinical assessment and management point of view. Clinical settings, overemphasis, it has to be emphasized again and again. You should always take a good history, and the clinical examination is equally important to elicit certain signs of deficiency, because there is no substitute for good clinical examination and good history, even if you do all that test. So this is how in real world we do in our setting. If the patient comes to as a clinician, we of the whether there is any likelihood of PEI, and if any patient's morphology is whether there, at least we do cross-sectional imaging, we do stool test, and in indirect tests we don't do directly in the clinical setting. We normally don't do direct tests, we do indirect tests, and especially we do fecal elastase in our clinical practice. Thank you very much for this is the last.